Well, thank you very much for inviting me and giving me the opportunity to talk a bit about radiotherapy for pediatric brain tumours. And as you've been told, I'm a radiation oncologist working at Karolinska University Hospital. So how does this work? How does radiotherapy has this dramatic effect on a brain tumour and also at the symptoms that it causes? Well, I'll give you some hardcore physics to try and explain that. the easy version. So what is radiation? Well, radiation is energy in movement, and the energy moves from a transmitter to a receiver. And in our case, the transmitter is usually a linear accelerator, could also be a decaying radionuclide, like a radioactive substance. And the receiver is a patient. And talking about radiation, it could be either non-ionizing or ionizing. But when we're talking about radiotherapy, it's only the ionizing effect that we're after. So we're talking about the ionizing radiation, because we'd like to use this ionizing effect to cause DNA damage. And this is a schematic figure of a cell with DNA in it and a DNA damage caused by radiation. So what happens next? Well, either this damage could be quite small and the DNA repair system can handle that, and the cell will repair this problem and the cell can go on as nothing has happened. Or there is a quite severe damage and the cell will die. Or we could end up somewhere in between with an improper repair, and this causes a mutation. And the next time around, when this cell is trying to divide, it could either detect this time around that this quite a severe damage and the cell will die now instead. Or this mutation can go on and eventually cause another cancer. And this can seem quite paradoxical, that a treatment that we're using to treat cancer also can cause cancer. And in our adult population, I mean, we mainly treat adult patients with radiotherapy, and in our adult population, they're usually in their 70s when they get their radiotherapy, and it's not a big clinical problem. Only maybe 1 or 2% will be affected with a secondary cancer after the treatment. And as they're in the 70s, they might die of other causes before they can actually acquire this secondary cancer. It usually takes more than 10 years to get a secondary cancer. This is completely different in the pediatric population, or when we're treating either children or young adults, because most of these patients we will cure, and they will have a very long life ahead of them, actually having time to develop this secondary cancer. And also in this population, we see that they might be more prone to actually developing a secondary cancers. Maybe the cancer they got in the first place was due to some deficiency in their DNA repair systems. So we try our best not to give radiotherapy to any children or any adolescents. But there are cases that is where radiotherapy is a necessity to actually achieve cure. Ionizing radiation could be in some different categories. If we start with electromagnetic radiation, this could be seen either as a wave or a flow of little packages of energy without mass, and these are called photons. And this is by far the most common sort of radiotherapy. Like at Karolinska University Hospital, we have 8 machines and they all give photon radiotherapy. We could also give radiotherapy with particles. That could, for example, be either electrons or protons. And electrons, we could give electrons in our normal machines back home. It's just we remove a filter and out comes electrons instead of photons. A bit simplified, but approximately something like this. But for protons, these are very large particles. We need a huge machine to actually be able to accelerate these in the sufficient speed that we need. And we only got one of those machines in Sweden, and it's at Scandion Kliniken, situated here in Uppsala. these different kinds of radiation, they're all equally good at treating and curing cancer. There's not one that is more efficient than the other. But they have some different traits that make them more or less useful in different situations. So looking at this graph, here on the y-axis we've got dose, and on the x-axis we've got distance from the skin and into the body. And if we're starting looking at electrons here, we see they've got a high dose just superficially. Then about 10 centimeters within the body, it's 0. So electrons we could use for treating like really superficial lesions, like skin cancer. Photons, on the other hand, they have a very high dose, maybe a couple of centimeters within the body, and then it drops really slowly and never becomes 0. So photons we can use to reach tumours that are further within the body than just superficially. And then comparing that to protons, they have a very low entry dose, and then they release all their energy at one single point, and after that is nothing. This can be very useful if we're treating something that we have a delicate organ at risk that is situated in the distance of this target, and we could spare that volume from being exposed to radiation. This is an example of comparing a proton treatment plan with a photon treatment plan of a brain tumor. So looking here at the proton treatment plan, we're trying to radiate this pink line. And you see here there's a nice high dose, the orange-red, that is conformal to this tumor, and it's only like a brim of the lower doses around this, and the rest of the brain is no radiation at all. Comparing that to treating the same tumor, but with photons, you see the same nice high conformal high dose around this target that we want to irradiate, but around it we can see like a low dose bath in all the levels that we are treating. And this low dose bath could potentially give late side effects. Radiotherapy is often given in multiple treatment sessions, and one of these treatment doses is called 1 fraction. And an example of clinical fractionation for a head and neck cancer could be 2 gray times 34 with a final dose of 68 gray. So why do we fractionate? Why don't we just give it all at once? I'll try to explain that. This is a graph showing cell survival on the y-axis, and it's a logarithmic scale. So up here, 100% of all the cells are alive, and down here, only 10% are alive. And on the x-axis is radiation dose, and you can see here that spotted out 2 gray here. And now we're comparing how radiotherapy works in late responding tissue, that could be nerves or muscles, compared to early responding tissues like mucosa or tumor. And we can see that normal tissue could better withstand radiotherapy than tumor cells, at least for about 2 gray and less. And if we repeat this, this is the same sort of graph with the logarithmic scale for the cell survival here on the y-axis, and then dose on the x-axis. And see what happens if we're starting with the tumor cell, what happens when we fractionate the radiotherapy. So we give 1 fraction, some of these cells will die. And tomorrow we give another fraction. A few of the cells have repaired since yesterday, but then we kill off a few more. And we keep doing this, and more of the tumor cells will die. Comparing this to normal cells, not as many will die, and a bit more will actually repair until tomorrow. And if we keep on repeating this, the difference between the normal cells and the tumor cells will be larger and larger. So we're actually exploiting the fact that normal cells have better DNA repair systems than the cancer cells. We're using different kind of fractionation schedules to depending on what intent we have with the treatment. So if we have a curative intent, we're trying to cure this patient from the cancer, we need a high total dose. And to achieve this, we need to do it with lower dose per fractions. We think it's acceptable with some acute toxicity as long as the patient could withstand the treatment that we've planned. But we would like to avoid late or chronic side effects. And a treatment could look something like this. Like we give 2 gray times 34. They will have treatment Monday to Friday every day, and the entire treatment will take about 7 weeks. If we have a palliative intent, we're just trying to help out with some sort of symptom, we don't need as high total dose. It's sufficient with a low total dose, but to achieve what we're after, we need higher doses per fraction. We really like to avoid acute side effects. The patient comes to us with a problem. We wouldn't like them to feel worse when they're leaving us. But it's not always so important to consider late side effects. As the patient has a limited life expectancy, they might not have the time to actually develop these late side effects. And the treatment could look something like this, like 4 gray times 5. They're done in a week. Or if it's just like a painful bone metastasis, it's sufficient to give a single fraction of 8 gray. Talking a bit about the side effects of radiotherapy and now focusing on the CNS tumours. Some of the acute side effects that we see is nausea, hair loss and fatigue. And I would say that today we've got very efficient medications to treat nausea. So this is not really usually not a big clinical problem. So I would say most of our patients are actually doing quite well during the radiotherapy. They usually tell us it's better than the chemo. But for late side effects, we can see things like permanent hair loss, neurovascular changes, which could then in turn have like very late side effects like things like stroke that we saw earlier on, or the microbleeds. We also see neurocognitive changes, things like brain fatigue, a decrease in processing speed, decrease in IQ, and problems with memory or attention. And neurocognitive side effects after brain tumor treatment is multifactorial. That is, there are multiple factors that actually affects the end result, or the late side effects that we see. And things that could contribute are the tumor itself. It could grow into delicate structures or important structures. The surgery, also radiotherapy, or the systemic treatment, or things like hearing loss or loss of vision due to either the tumor or the treatment could actually affect the neurocognitive abilities later on. And this is a massive initiative that was started in 2012, the PENTEC, the Pediatric Normal Tissue Effects in the Clinic. It's radiation oncologists and physicists that tried to find correlations or causations between radiation dose to specific organ systems and late side effects. And they looked at 14 different organ systems: the brain, hearing, spinal cord, muscles and bones, lungs, the reproductive system, both male and female, re-irradiation, secondary cancers, urinary tract, gastrointestinal tract, breast, heart and vision. And it was all presented at PSYOP last year. But now we're focusing on the brain. So this is the neurocognitive effects and necrosis in childhood cancer survivors treated with radiation therapy. And in this paper, it was stated that radiotherapy is an essential part of brain tumor treatment, but it is associated with neurocognitive side effects. And the main neurocognitive deficits appear to be difficulties acquiring new abilities, rather than loss of skills or knowledge gained before the cranial radiotherapy. And this partially explains why children treated at younger ages have more severe late side effects than children treated maybe in their teens. So they tried to find the effect of radiotherapy and tried to correlate this to neurocognitive impairment, brain and brainstem necrosis, subacute somnolescence syndrome, chronic headache, brain atrophy, and leukoencephalopathy. And they started out with more than 4,000 abstracts and ended up with 43 that were actually good enough to be included in this study. And they also had to settle with looking at neurocognitive impairment and brain and brainstem necrosis. There weren't enough data to actually get any results or make any conclusions for the rest of these syndromes or problems. And this is a graph showing the results of this study, and the graph showing risk of IQ under 85 after radiotherapy. So this was their definition of a clinically significant decrease in IQ. And they found that the risk of side effects is dependent on volume and dose. And this shows the risk of an IQ under 85 on the y-axis and dose on the x-axis. Trying to interpret this, this is an example. Starting with this red graph, it shows whole brain radiotherapy. So if you would irradiate the whole brain to about 34 Gray, you will end up with the risk of about 50% acquiring an IQ under 85. And this is quite similar to what we give to the medulloblastoma, high-risk medulloblastomas. 1.8 Gray times 20 equals about 34 Gray in EQD2. So they will have about a 50% risk of clinically significant decrease in IQ. But comparing that to partial brain radiotherapy, here in green, you can see if you irradiate only 10% of the brain to a bit more than 50 Gray, then you will have about a 20% risk of this of an IQ under 85. And they also found correlations on age and concurrent chemotherapy, that these could add to the risk of having a lower IQ. And this graph trying to combine all these factors, age and methotrexate, and starting with whole brain radiotherapy. And here they have an estimate of how much in points the IQ will be decreased after this treatment. So looking here at if you give a whole brain radiotherapy, just as an example, of 20 Gray to 15-year-old without methotrexate, you will have an expected 5-point drop in IQ. Comparing that to treating a 5-year-old with methotrexate, the same whole brain dose of 20 Gray, you will have more than like 12 or 13 points decrease in IQ. And this is the partial brain radiotherapy, and this is defined as posterior fossa treatment or tumor bed treatment. And this is only radiotherapy, no methotrexate. And this red bar here sort of indicates where we usually end up. It's a bit more than 50 Gray to 59 Gray, like you would give to a low-grade glioma or to an ependymoma. And at 15 years, 10 years, and 5 years, you will end up with a decrease in IQ of about 7 to 12 points. So take-home message is that radiotherapy for pediatric brain tumours is associated with neurocognitive side effects dependent on age, dose, volume, and concurrent chemotherapy. But today's knowledge is based on poor data, and I would say very poor data, and old treatment techniques. And with an increase in knowledge and now more modern techniques, we hopefully will see less side effects in the future.
Thank you so much. Very informative. Questions?
Excellent talk, Anna. Very informative. When you talked about the fractionation, there is these bumps. So going from 0, there's an increase in cell survival with each fraction. Something is increasing before it decreases. Or how do I interpret the shape?
You should probably think that as more schematic than exact, but that is usually how it is shown. And we know that sometimes lower doses also can proliferate cells, so maybe something like this. But I think you should interpret it more of a schematic figure than the absolute truth.
And a follow-up question to that, also connected to what you just said, is there such a thing as a safe, lower radiation dose? Can you extrapolate to...
I mean, I would say no. I think that all radiation could cause you harm. Even, I mean, the background radiation, if you're flying an airplane, will give you a higher risk of skin lesions or skin tumors. So we know that radiation can cause DNA damage and have effects. But I think there are probably lower doses that you won't see any clinical effects, like in neurocognitive effects. That are doses that could be considered safe.
Yes, we have another question there.
Excellent talk. So it's the last sentence on your slide there. With increased knowledge and modern techniques, we will hopefully see much less effects in the future. Could you expand on this? I mean, because the radiation is still the same in amount. Is it just because the volume that is affected is a little bit less? And to what extent can we expect lower side effects?
I think it's difficult to know to what extent, because we would need like 20 years or 30 years of follow-up to actually know. And by 20 or 30 years, the techniques have changed so much, we don't know what we're actually looking at. But we know for sure that we treated larger volumes if we go back only 10 years, but most definitely if we go back 20 years. Like the thing that you talking about earlier on, do you think proton treatment is the answer to everything? I don't think. I think proton treatment as photon treatment could be looked at in the same way. We need to look at what volumes we're actually getting irradiation. Sometimes photon is superior to protons and would actually give treatment to a smaller volume because they have different traits and we have to use them in different situations. But hopefully, in 10 or 20 years' time, we now have all our data in computers, so we can actually see what we've done, and we can look at what dose this structure got 20 years ago. But today, if I'm looking back what happened 20 years ago, it's on paper. If someone had drawn a few figures and a body, and it's like a cross in a paper, I can just guess what dose that organ actually got.
Hello. I know that we ask you that you should tell us about the normal organs, what risk dose they have got. Do you sit with the 20-year-old to say that this has got an irradiation dose that is risky for that organ, like hypothalamus, hypophysis, or whatever. And you do that even with those old data, as you say. But when you get the risk dose, how good are the data to tell what could happen after special doses?
I think that we actually know quite well, but mainly based on when we're doing like whole brain radiotherapy or whole like mantle radiotherapy for lymphomas. But when we're getting to the smaller structures, it's more difficult because we don't have that data. We only have the data of the prescribed dose. So we know that we gave 54 gray to this patient, but if it was a small tumor or a small volume, we don't know what else got that dose. But if it's like a large tumor, we know that this was within or a whole brain radiotherapy, the prescribed dose is quite similar to the dose that are actually given. So for some organs, I think our guesses are quite good, but we could probably do much better like prioritization if we knew more exactly which structure is more delicate than the others. Should we prioritize the hippocampi over the temporal lobes, or because somewhere the radiation actually has to get into the body? But I guess that we will know more and more since we actually got more data now on actual doses to specific organs at risk. But all old data is based on prescribed dose, and that there was some homogeneity in the dose that was actually given.
Okay. Okay, one more question then. And then we'll move on.
Oh, I have a question for the future. I'm a neuropsychologist, and I'm doing my PhD about radiation doses risk at our organs at risk and look at cognition. And we have one was delineating the structures, and it's very difficult. And when I'm reading all the articles, what do you think about AI in the future? And we, of course, need humans to also look at it, but the combination, because it takes a lot of time to do this delineation, I understand it's very complicated, and also one person can delineate it differently from another, so it's very complicated to do this. And do you think we could in the future be better to use the technology but not overuse it? What do you think about the future?
Definitely. I mean, we had many they use AI daily now in the daily clinic to delineate all organs at risk. We had one system, but they had some legal issues, I think, so it now closed down, so we need to buy another one. But I think the most difficult thing here is actually GDPR for us, because we would like it to be a learning process of the AI, not just having a library, but they should actually learn. And if they should learn, they have to have access to all the data of the imaging, and that's a legal problem. But I will definitely say that we will not, looking at Anna's also radiation oncology, we won't delineate in 5 years or 10 years' time. We will just review.
Perfect. Thank you so much, Anna.